Hi, my name is Kaavya Puttagunta, and I'm an M2 at the University of Michigan Medical School. And though I'm very disappointed to not get to talk to you about this in person, I'm excited to at least get to share with you in this way institutionalizing health justice frameworks in medical education curriculum. Though the pandemic and societal reckonings have made national conversations about health inequities more prevalent and timely than ever, medical education itself, unfortunately, has not quite discussed and contributed to their own role in precipitating these exact health inequities and injustices. Though there is a significant increase in the research and self-recognition amongst medical educators about how medical education contributes to perpetuating health injustices through a lack of intersectional health and justice concepts in medical education, as well as a culture that deprioritizes marginalized populations, there often aren't the tools themselves to actually begin redesigning these curricula. This is where our project comes in. At Michigan itself, the 2019 preclinical curricula or climate survey showed that a majority of students who identified with minority groups felt that the curriculum didn't represent social determinants of health, the perspectives of marginalized populations, or their own identities in a significant way. It was especially difficult to stomach, contrasted with how their majority group peers felt their identities were represented. This kind of lack in understanding of where medical education can itself make a change is exactly why a group of students with diverse personal and academic backgrounds began to create a toolkit with specific problems highlighted through examples in U of M's own medical education curriculum, as well as through a massive literature review, and found specific examples and methods for how to make changes in the curriculum that could make meaningful medical education and clinical practice changes that could then change the representation that we saw, or actually change some of the problematic practices based on things like race-based education or things like a lack of understanding different perspectives and the priorities that different groups may have in medical practice down the road. An example can be seen here. With specific concerns and solutions highlighted and exact examples from things seen in the medical curriculum, as well as a checklist that has sort of a more summarized a set of the recommendations that educators themselves can use and go through and edit their lectures in a systematic way. The framework recommendations were split into 4 groups: visuals, language, historical context, determinants of health, to help focus reviews. But as we began the process, it was very clear that not only did these need more than one edit, they ended up needing edits in nearly all 4 domains, at least 2, if not more. To help get this project going, a group of students worked with a pulmonary sequence group to actually begin editing and systematically reviewed 14 lectures, making over 131 edits alone. This was not including the faculty edits that were being made based on their own learning using the toolkit. Through this review, not only did it become clear how much these perspectives weren't actually included in medical education in general, but how many changes could be made and how quickly these could be made with a systematic process. The Curriculum Policy Committee at the school actually endorsed this project and introduced it to the clerkship directors as well as the clinical educators to help facilitate this process. An example revision is below. Making changes that increase representation not only helps students better visualize different conditions on different types of patients, but also helps students feel more represented when their own identities are represented in the lectures, giving more confidence to students as well as teaching them how to recognize different concerns in different patients. The project and the framework itself was hugely successful at U of M, and not only facilitated administrative work groups, exam reviews, and the preclinical sequences, as well as an entire new curriculum in the clinical trunk itself, There are also many projects at hand for furthering the framework itself, as well as incorporating it into graduate medical education, including residency education. Of course, this project requires significant more evaluation, revision of the framework itself, and expansion. We're very excited that this type of thought has been well represented in medical education, but now there are actual tools of how to make those changes. When you see the concern, there's not much you can do if you don't have the methods for where do I begin making the changes? Where do these impact different groups? And so we hope a project like this can really showcase how outlining the process will help make medical education more inclusive and more equitable in the practice, as what we learn is exactly what becomes clinical practice and contributes to the disparities we see. Thank you for letting me discuss this project, and I hope that I'm able to answer any questions, as well as Katie Neff, my partner, if there are anything that comes up. Thank you again for letting us discuss this project, and we hope that you have a great day. Of course, we'd also like to thank the many, many people who helped us make this happen.